What's important for you is how do you portray this information to your patient who's sitting there dying. They want to go and get their detox medicines. They want to go out and leave the facility and get the medicine they were taking. They want to do anything to take away this pain. How do you transmit this issue and motivate them to, number one, consider coming off the very thing that's causing it, which is a very big challenge in the industry, as you understand. Well, the way I do it is I give them several metaphoric descriptions of what's happening. Firstly, I describe this as having a good night's sleep, which of course the patient hasn't had in a long time, so they really listen to you when you tell them this. And let's say if you had a nice long night's sleep and you didn't wake up until it was bright, bright, bright outside, I ask them, what's the first thing you do when you wake up? Well, the patient thinks for a second. They say, well, I go have a cigarette, I go take a few Percocets, I go do all these other things. I go, no. But before all that, what do you do? And I play with them a little bit to get them hooked, that kind of before I set the hook. I said, the first thing you do is you open your eyes. And then I ask them, what's the second thing you do? And what they do is then they squint or close their eyes because the light is so their eyes are so hypersensitive to the ambient light, although normally when you're awake it's no big deal. When you first wake up, that light is actually too intense and sometimes too painful, so you have to squint and close your eyes. And I explain to them that their nervous system, I don't have to get into all of this. I say their nervous system, because they've been on pain medications for, so I ask them how long they've been, for 2 years, 4 years, 5 years. Your pain fibers have been asleep and now they're trying to wake up. And this is why you're perceiving this pain. The brain needs pain information to keep the body safe. And I talk about touching a hot stove and how the protective function of the brain is with respect to the pain fibers. And this is very important. And for however many years they've been on this, they've been depriving their brain of this very important life-saving and life-preserving information. So the brain, through a survival technique in a compensatory manner, tries to listen harder and harder to retrieve that very vital, protective, important information. And it's through, actually, it's been shown scientifically now. I was telling this for a lot of years without any scientific basis, but I'm thankful this is out. By being hyper-vigilant, listening for this information, the body is trying to protect itself. And now when you go through withdrawal and you take away the pain medicine, now the pain system wakes up and all of a sudden says, did you get the number of that bus that hits me? And say, what's happened? The brain, who's listening real tightly here, all of a sudden says, whoa, what was that big noise? And now the patient going through withdrawal is now receiving this pain information, and now because of the hyperalgesia and because of this protective measure that we just talked about, it's magnified significantly. Luckily, that can be returned to normal, and we're going to talk about that. So it's very important that you develop what I just gave you, 2 silly little metaphors that I use with my patients, but you need to come up with an allegory, some way to transmit this science to your patient, because like I said before, the pain for your patients is real. They are trying to make sense of it. They're linking it up to a past injury. I played football in high school. I fell down the stairs when I was a kid. I was in a car accident in 2006, and they're trying to make sense of it. And what you have to do is to show the patient that that's not the cause of their pain. This is the cause of their pain, and that motivates them to try to get better and to change.
If at the end of the treatment, that patient understands this is only the end of this section. Now I need to continue with psychotherapy. I need to understand the anxiety, the depression, the stresses in my life that are going to have me experience pain even more than I'm experiencing right now. I actually believe that about all people who are in rehabilitation, but I'm concentrating on this right now. As a psychologist coming into this field, it struck me how there isn't as much of this as I would like. That what happens is such a large recidivism rate with our patients. We treat them, they leave, and then they come back. And why? Why would that be happening? And looking at what are we doing? Understanding our patients, understanding what their needs are, and then applying the proper strategies to those needs, and then assessing before they leave, how well are we doing? And that's a component of this program that I also consider unique. Our Pain Recovery Institute, it is part of the treatment center of the Palm Beaches. It is one of the tracks that are in that center. In that center, there's 130 beds of inpatient beds, 30 patients usually assigned to chronic pain. And what we define chronic pain as, it's normally defined as having seen a physician for chronic pain 6 months prior to the admission. Now, we get a lot of other patients in the program who have pain and they get services, but they're not in our chronic pain program. Each patient is assigned to a designation called P1 or P2. P1 are those patients who are dependent upon prescription medications. And they haven't used and abused other substances or alcohol. They were just people who were dependent upon it and were given to it after a surgical, after an injury, and they became dependent upon it and want to stop that medication now. The second is the P2 patients. They're dependent upon it, but that's a different population, I felt. That's a population who often were abusing drugs before and alcohol before they have the pain medication. Now they're abusing those in addition to everything else. And I wanted to keep those numbers separate while we try to collect our data, because I think we're going to find that different things work differently for each of those populations. And even though we suspect that now, I would like to get some proof about that.